So, good morning, everyone, and welcome to the session on national dementia strategies. I'd like to start off by thanking you all for coming today and for coming to the session, which I'm sure is going to be very interesting and very informative. We have a fantastic range of speakers who will be joining us today and presenting on different aspects of the work going on in their respective countries in relation to national dementia strategies and specific dementia policies which have been or are currently being implemented. So just a quick few housekeeping rules. As with the previous couple of days, and you're probably all experts at this by now. If you have any questions for our presenters at any time, please feel free to ask them within the group chat. Having spoken to our presenters to begin with, just before the session started, we've agreed that we'd prefer just to take the presentations all in one go, and then we will ask the questions at the end. That way it gives the presenters some time to think about their responses and also allows other people to maybe contribute if they have something from their country which they'd like to contribute as well. So to begin with, I'd like to introduce Nils DAHL from the federal German government. He is the Senior Policy Advisor at the German Federal Ministry of Health. One of his main tasks is to coordinate Germany's national dementia strategy, which was published this year, and is also involved in related research projects. So his focus today is going to be on the development of the German national dementia strategy. So I'd like to hand over to him now.
Hello, everyone, and good morning. I'm happy to introduce you to Germany's National Dementia Strategy today. The strategy was developed in 2019 and 2020 under the lead of the Federal Ministry for Family, Older Persons, Women and Youth, as well as the Federal Ministry of Health, which I'm representing today. Next slide, please. The strategy was adopted by the Federal Cabinet in July 2020, and it's based upon quite a number of previous measures and programs that were initiated by the federal government, but also based on measures of the state governments, of local governments, and other organizations. And the dementia strategies of other countries and international action plans, such as the WHO action plan on dementia, were considered as well. Next slide, please. Here you will find some of the preceding measures that were initiated by the federal government. For example, in 2009, the German Center for Neurodegenerative Diseases was founded, and it's still funded by the federal government and by the state governments. In 2012, the so-called Alliance for People with Dementia was started, and the coalition agreement of the current government said to further develop this alliance, and this ultimately led to the current strategy as we all know it now. In 2017, people with dementia were or the access to long-term care insurance benefits for people with dementia was improved, and the benefit level were considerably raised as well. And in 2019, the so-called concerted action for the care workforce was started. And I think this is also an important point in this context, because as working conditions and qualifications of the care workforce are improved, we hope that the situation or the quality of care for people with dementia improves as well. Next slide, please. This is a picture of the official start of the implementation of the strategy in September of this year. In the middle, you see Minister Giffey, the family minister. On the right, you see Mr. Spahn, the health minister, and on the left, you see Mrs. Karliczek, the research minister, played an important role in the process as well. Next slide, please. This is the title page of our strategy. The strategy includes 4 priority fields of action, which I will present afterwards. It includes 27 goals and over 160 concrete measures that all involve actors agreed upon. To agree on these measures, 72 partners were involved in the drafting process. And the next slide shows who these actors are. Next to governmental actors of all levels, meaning the federal level, the state level, and the local level, providers of healthcare and long-term care, professional associations of the care workforce or of specialists and general practitioners were involved as well. The healthcare and long-term care insurance funds, of course, research institutions and civil society organizations as well. Most importantly, the German Alzheimer Society served as a vice chair over the whole development process. I will now, on the next slide, introduce you to the 4 priority fields of action that I have just mentioned. Number 1 is to build dementia-inclusive communities to enable the social participation of people with dementia near their homes or their place of residence. Number 2 is to improve the support for persons with dementia and their family caregivers, because in Germany, most people with dementia are cared for by family members or relatives. Number 3 is to improve care or the quality of care in all health and care sectors. And number 4 is to promote research on dementia, on, for example, clinical research, but also prevention research or research on the care provision and other aspects as well. I will now give you some examples for these concrete measures that I have just mentioned. In the first field, a dementia awareness campaign was already started by the federal government. It includes quite a number of partners or other actors, and uses different communication channels to address the various target groups to raise awareness on dementia or the challenges for people with dementia and their caregivers over society in general. More local and regional networks are to be founded. We have different funding mechanisms that we can use for these networks. For example, the local, the long-term care insurance funds provides funding for such networks, or the family ministry started a federal program to further increase the number of local networks or so-called local alliances. The reason behind is to further facilitate the exchange and cooperation between local actors. And there are other measures such as the improvement of mobility services and others. I can't go into detail too much right now. In the next field, so next slide, please. We want to expand already existing counseling and assistance services that are provided by volunteers as well as by professionals. In this case, we want to examine whether professional dementia care management can be implemented as an additional benefit of long-term care insurance. We want to encourage programs, qualify LTC guides or dementia guides in companies, and also new prevention programs for family caregivers are important as well. Next slide, please. We want that the needs of people with dementia are to be considered in regard to adequate staffing and the organization of work processes in all care sectors. We want to improve the qualifications of professional care staff, for example, by supporting additional dementia-specific training for care workers and nurses, as well as dementia-specific basis qualifications for other staff, such as cleaning staff in care institutions, so staff that might have contact to persons with dementia, but are not involved in the provision of care services. We want to support the dementia-sensitive design and architecture in hospitals and care facilities, and we want to foster cooperation between all relevant healthcare sectors and actors. For example, between hospitals and short-term care facilities to improve the service provision in this context. Next slide, please. In the fourth field of action, we want to improve or expand the cooperation between research institutions by expanding a national clinical dementia research network and by expanding a national network for dementia healthcare services research. Access to necessary data is to be simplified. Funding will be extended, and especially the transfer of evidence-based strategies for prevention or healthcare provision, and also therapy to implementation in practice is to be improved as well. Next slide, please. All these measures, I know it's quite a number of measures, will be monitored until 2026. There's also a steering group that controls or checks this monitoring process. And in the end, there will be a monitoring report to see if the strategy needs a further development or improvement. And also a complementary network, national strategy on dementia, will be founded to foster the cooperation between all involved actors on the long run as well. And yeah, of course, COVID-19 had an impact on our strategy or on the implementation as well. So some measures might need to be adapted, and all actors will take that into account. But I think it's important to say that the implementation of the strategy and dementia as a topic will remain a priority for the federal government. And I think the fact that we adopted, or that the federal cabinet adopted the strategy in these times, is an important signal in this context. Yeah, I would like to thank you for your attention, and I'm happy to answer questions. If not today, you can also use these contact details to reach out. Thank you.
Thank you very much, Nils. That was a really interesting presentation and a great overview of the work that's taken place in Germany over the past few years. I think it's really interesting to see that a lot of the areas and the fields of action which you've covered there are really reflected in some of the issues which have came up quite strongly during the course of the conference as well. And it's great to see that Germany is especially committed towards research as well as a sort of key part of the strategy. I'm going to move now to the next speaker. I see people have already begun to ask some questions in the chat, which is great. And as I said, we will take these at the end. I'm going to move on to our next speaker. Unfortunately, I don't think I see Louise Hopper within the chat, so I shall take the speakers after, and if Louise joins us, we can take her presentation at the end. So I'd like to introduce Teija Hammer and Seija VILJAMAA from Finland. They are going to speak to us today about the Finnish Age Strategy and the promotion of implementation of memory-friendly practices within Finland. Teija is working as the Chief Specialist in Aging, Disability and Functioning at the Finnish Institute for Health and Welfare. She's been involved in many nationally and international research and development projects in the area of health and social care concerning services for older people, especially home care, quality of life, integration of services and end-of-life care. And Seija has been working as Senior Specialist in Functional Capacity Unit at the Ministry of Social Affairs and Health. She's participated in many developmental projects in the field of health care and social welfare, in particular with regard to advice, service, guidance and assessment of the needs for care and the development of older people's services. So I'd like to introduce the two of them, and they will be doing a video presentation.
Hello, dear audience and colleagues. My name is Seija VILJAMAA and I am working as a senior specialist in the Ministry of Social Welfare and Health. It's my pleasure to give a short presentation about Finnish Age Strategy and how it promotes implementation in memory-friendly practices. Teija Hammar, who is working as a chief specialist in Finnish Institute for Health and Welfare, gives this presentation with me. First, we will tell you very shortly some background information about Finland, then present Finnish service structure and aging policy, and finally introduce what we have done and what we are going to do to move towards a memory-friendly Finland. In this slide, you can see some facts about Finland. For example, the population is over 5.5 million. And then we have, of course, Moomies and Santa Claus here in Finland. And as you all know, capital city is Helsinki. Finnish population is aging very fast. At the moment, 20% of population is above the age of 65. And the share of the elderly population is increasing. As the population ages, the number of people suffering from memory disorders are also increasing. Progressive memory disorders pose a huge challenge for public health and national economy. On this slide, you can see some numbers of memory disorders. Now we are moving to look Finnish health and social structure. At the national level, the Ministry of Social Affairs and Health is responsible for general planning, guidance and monitoring of health and social services. The Ministry lays down the legal framework for the production of health and social welfare policy and legislation. The National Supervisory Authority for Welfare and Health is a central supervising authority with regulatory tasks such as licensing and performance auditing. Valvira cooperates with 5 regional administrative agencies that have primary responsibility of supervising social and healthcare in their own region. Finnish health and social care system is highly decentralized. In Finland, there are over 300 municipalities. They enjoy significant autonomy over the planning and organization of health and social services. They are responsible for providing services. Municipalities can produce services themselves together with other municipalities or by services from non-governmental organizations and private companies. They also are in charge monitoring and coordinating services for people. The challenge in Finland is that we have so many different kinds of municipalities with small and large population, with long distances, rural areas, and so on. And therefore, the availability and use of services varies between them. Then I'd like to tell you that we have a huge health and social services reform on progress. The responsibility for the organization of health and social welfare, social services will be transferred from municipalities to 22 counties, and at the same time, the content of services will be also developed. Then some words about aging policy. The aim of Finnish health and social care policies is to promote people's functional capacity and well-being, independent living and active participation in the society. The service structure has been lightened over the years, and many older persons, including persons with memory disorders who need services, live at home support by home care or live in a service house with 24 hours assistance. And I want to say that in Finland, the individual own view of his or her health and the need for help is the starting point to organize services. In the Prime Minister Marin's program, Health and Welfare Promotion and Decline Functional Capacity Prevention have been emphasized, and memory disorders have been raised to the same level as other chronic diseases, such as diabetes and heart diseases. In order for us to be able to meet the increasing demand for services and costs, we need action to promote brain health, to prevent memory disorders, and to detect memory problems as early as possible. And here in Finland, we are working on these things now. Finland is currently reforming Elderly Care Act. The Act will be reformed in two phases. The first stage has been completed. It includes the long-term care nurse-client regulation of dimensioning. The dimensioning rises gradually so that in August 2020, the ratio was 0.5, and it means 5 nurses, nursing staff per 10 clients. And from April 1st, 2023, the ratio should be at least 0.7. The other major reform is that national implementation of the Inter-RAI assessment system. The reform of phase 2 focuses on the development of home care and informal care and different forms of housing. And this second phase planning has already begun. The Ministry of Social Affairs and Health has published the horizontal program of aging that helps to prepare for the social effects of the aging population in the longer term. This program was prepared jointly by different actors. Program deal with supporting the good health and functional capacity of older people, utilizing technologies to improve the well-being of older people, strengthening the role of voluntary work, increasing the age friendliness of housing and living environments, and providing customer-oriented services. And in this slide, you can see the contents and impact targets of Finland's new national aging program. VILJAMAA will now continue and tell more about how we implement and and following up our aging policy.
Thank you, and hello everyone. I'm happy to continue from now. Let me give a brief overview of our tools for implementation of old age policy goals and moving towards a memory-friendly Finland. At the same time as the National Programme on Aging, a new quality recommendation to guarantee a good quality of life and improve services for older people was also published. The thematic areas in quality recommendation are similar than in the Programme on Aging, for example, supporting the good health and functional capacity or providing oriented services, as we just hear in Seija VILJAMAA's presentation. Quality recommendation takes, among other things, into account memory disorders in service coordination, identification of disorders, attitudes of the general population, or how to face a person with memory disorders. The quality recommendation gives recommendation for each thematic areas and presents good practices that support the implementation of the recommendation and aging policy. Quality recommendations support the functioning of the elderly population as well as the implementation of the Elderly Care Act and the reforms made to it. The recommendations give also tools for municipal policymakers and leaders to implement aging policy and the government program in practice, and tools in the development and evaluation of services for the older populations. Our National Memory Program and its action plan are going to end in this year in December, but we are happy to say that we don't longer need a separate memory program because the themes and items previously included in our National Memory Program are now within this National Program on Aging. Issues are being implemented in ongoing national programs. Many good practices have already spread and implemented in our country as well. Health and social services will be developed during the Health and Social Services reform as part of the Future Health and Social Services Centres program. This development program has launched by the Ministry of Social Affairs and Health, and it will be implemented in 2020-2022. In this slide, you can see 5 key objectives of the program. The aim of the whole health and social service reform, like this program, is to strengthen basic services, increase service quality and effectiveness, and improve equal access to services. Focus of services will be shifted from specialized healthcare to primary healthcare and preventive work. Further, the role of social welfare will be emphasized more than previously. It also aimed at improving people's trust in public health and social services. This program will be implemented in the form of the development projects carried out around Finland, developing also services for persons with memory disorders. The Finnish Geriatric Intervention Study to prevent cognitive impairment and disability, so-called FINGER, the results showed that lifestyle changes in older population are effective in declining the risk for cognitive decline. Intervention consisted of regular meetings with physicians, nurses, and other health professionals, healthy diet, exercise programs, and management of metabolic and vascular risk factors through regular blood tests and other means. The intervention group improved more in all studied cognitive domains, for example, executive function, processing speed, and complex memory tasks. National implementation of the FINGER model will continue in social and healthcare reform and on program for health and social services centers of the future. And let me end by introducing some databases, statistics, and studies. The Sotkanet Indicator Bank is the GHL information service that offers key population welfare and health data from all Finnish municipalities. Statistics Finland produced the vast majority of Finnish official statistics, for example, population, health, housing, and social protections. Status of Older People Services survey is conducted every 2 years. It tells the current situation of care for the elderly and highlights areas for development. And it follows up the implementation of legislation, for example, how the organizations will succeed to achieve this 0.7 staff ratio. And it also follows up the implementation of quality recommendation, aging policy, and national programs. Memory parameter is conducted every 5 years, and results from 2020 will be published by the Alzheimer Society of Finland. Thank you for your attention, and in this slide you can see our contact informations.
That's great. Thank you very much to both Seija and Thea for their presentation. I think there's a lot of interesting information in there, and it's interesting to see how the approach in Finland has evolved, and that this move towards to age friendliness in terms of the policy approach, I think, is particularly interesting, and something that you can definitely see where the areas of overlap are, and how there's actually a lot of commonality in terms of the approaches for this work. So thank you for those presentations. Again, there's lots of questions and discussion going on in the chat, which is fantastic to see. And again, we will take that towards the end. So for our next presenter, I would like to introduce Elisabeth RAPPOLD from Austria. She's going to be discussing dementia as a public health priority and looking at some of the current trends, and also looking at some of the best practice. Elisabeth's background is as a senior health expert in the health ministry in Austria since 2008, and she's specifically in charge of the care coordination department. Her work focuses on development of job profiles for health professions and for the evaluation of professional laws, the development of practical tools such as nursing documentation. As well as this, she also coordinates the care-related projects at the Health Ministry, including the participation process within the nursing reform. So I'd like to hand over to Elisabeth to present, and the floor is yours.
Yeah, thank you for the introduction. I'm not working for the Ministry of Health, but for the Austrian National Public Health Institute, and we cooperate a lot with the Ministry of Health.
My apologies, my German's not very
good.
No problem.
No problem. Okay. Dementia is a public health priority, current trends. Why is it a topic in Austria? The demographic change and associated slowly rising of dementia prevalence rates, as well as the growing care and the nursing expenses prompted the Austrian government to include the development of a dementia strategy in the government program in 2013 to 2018. And the Austrian Public Health Institute was commissioned in 2015 to oversee the development process of a dementia strategy for Austria. And this strategy was called Living Well with Dementia. And it was adopted by the Council of Ministers in 2016. Here you can see some figures from the Alzheimer Europe publication about dementia prevalence in Austria. The Austrian Dementia Strategy, Living Well with Dementia, provides a framework of objectives and recommendations for taking action to improve the lives of people with dementia, as well as their family and carers. We have 7 objectives in this area. The 7 objectives are formulated jointly by the federal government, social insurance bodies, the federal states, municipalities. We also included people affected with dementia and self-help groups and other institutions and professional organizations. The strategy itself, it tends to assist everyone on a national, regional, community and organizational level to develop a better understanding of dementia and to defeat the stigma attached to it. Another goal of our strategy is to focus on a better education and training of professionals and systematic data collection. You see quite similar to the German dementia strategy. We see a lot of success in our strategy, but it depends mainly on the commitment of all political and non-political decision makers, as well as service providers and people affected by dementia, in working together to achieve all those goals. We One recommendation in our strategy is to set up a platform for the dementia strategy. This happened in 2016, and the goal is to support the implementation of the 7 objectives and all the recommendation. We have a coordination group of 25 people which oversee the implementation process, and we meet 4 times a year. In 2017, the focus was on the collection of implementation measures in Austria, and you can see them on our national homepage, which you have seen in the first slide, www.demenzstrategie.at. It's in German only. In 2018, the focus was on expanding the platform for the strategy. And for the first time, we organized a working conference with about 120 participants. You can see it here in the picture. And from there on, we have annually working conference. This picture is from the second conference in Vienna. And in 2019, we tried to involve more the people with dementia in our activities and focused on capacity building among healthcare providers and the media. And I will go into the details for the last 2 parts a little bit later on. This year, we changed our format and we organized several online talks focusing on COVID-19 and its impact on people with dementia. Okay, now let me tell you about our 3 products, which we have developed in the past 3 years. The first is the guide for hospitals with the goal to enable hospitalization for patients with dementia as friction-free as possible. The second orientation guide for nursing homes has a different goal. It's in order to support and accompany people with dementia to maintain good quality of life, skills and abilities, and self-determination. And the third goal is for the media, and here in this orientation guide we focus from a deficit to a strengths-orientated reporting. All 3 guides intend to improve the situation of those affected, and while the 2 orientation guides for hospitals and nursing homes are specifically designed for the legal representatives or the overall management of institutions where people are treated or cared for, the target group for the third guide is art journalists on field level who have generally little to no knowledge on living with dementia. The development process of the orientation guides differ a little bit. The one for the recommendations for the hospitals, we started with a literature review, carried out some working groups with representatives from hospitals who already have developed orientations guides themselves, and then we carried out a peer review. During the literature research, we discovered the space principles from the RCN. You can see them here, that staff who are skilled and have time to care, partnership working in career with carers, assessment and early identification, care that is individualized, and environments that are dementia friendly. We used the space criterion to develop the Austrian orientation guide for dementia-friendly sensible hospitals. And we realized that all the other organizations used similar criteria, but hadn't based on the space criteria. We realized that we need an instrument to monitor the implementation of the space principles, and therefore we added dementia governance in our product. This is important because we see that people with dementia are increasingly being looked after in hospitals, but not necessarily because of dementia itself, but mostly because of other severe illnesses. And the treatment in our hospitals usually extends only to a few days. And with these orientation guides, the hospitals get some support how to create a suitable conditions for people with dementia during their stay in the hospitals. And we added also a chapter concerning the prevention from delirium or delirium management. But the orientation guide is not a clinical guideline. We do not focus on treatment and diagnostic. The orientation guide for the nursing homes is also based on the space criteria, but we carried out an additional literature review in order to gain an in-depth insight in this field. We carried out focus groups and which comprised residents of nursing homes, employees of all professional groups, nurse directors, and people from supervisory bodies. And then we drafted this orientation guide and carried out a peer review. What we think, it is important to have different orientation guides because while patients are admitted to hospitals for diagnosis and therapy, the main focus in nursing homes is on living, which means the residents are very often affected by diseases, of course, and they have restrictions and need to be treated properly and professionally. But nevertheless, everyday care in nursing homes is to support the pursuit of well-being and social functions, and of course support the process of dying. The task of the nursing home is to support people in their existence, to support them in regaining skills and abilities, and also to prevent psychological and physiological crises. In this sense, there is a different approach because nursing there maintains to restores, adapts to the physical, psychological, and social functions of the person to be cared for. And for this, a special professional knowledge is needed, and it must be reflected on structures and processes. The media guide provides a support for strengths-oriented and person-centered reporting. This was developed with the involvement of experts from NGOs who had experiences in a similar guide for people at risk of poverty. And this media guide has been developed with the group and has been reviewed by people with dementia. The background is that the current image of people with dementia and the public perception is mainly focused on the advanced stages of dementia and people living in nursing homes. With the media guide, we hope to focus on the different aspects of the group with all their problems and show them in different settings, like on the train station, or to show there's no difference. You can't see people who have dementia alone on their appearance. The purpose of this paper is to promote the consistent use of an appropriate language, which is inclusive and non-stigmatizing when writing or bringing pictures about dementia. Yeah, that's from the Austrian part. You can download our orientation guides for hospitals and nursing homes from our homepage. I gave you the link here, and the media guide will be finished within the next months, and I'm happy to share the link. So thank you for your attention.
That was great. Thank you so much, Elizabeth, for that really interesting talk and for the sort of detailed description of the approach that you've taken there. I think that's one of the things that sometimes when it comes to the discussions around policy and things, sometimes there is a feeling that it might be a little bit abstract, and sometimes the real interest and the real difficulty is how do you go about developing guidelines, and how do you go about implementing these different policies. So I think it's really interesting the way that you've described that there about how you've gone through that process of development and really involved people working in those different settings, and we look forward to hearing about how that goes in the future. So I'd like to move on now to introduce Ella Robinson from the Alzheimer Society in the UK. Ella is going to discuss with us today about the Building the Dementia Pathway, which is a project which was done by the Alzheimer Society, looking at what people's experiences were and mapping these against the national criteria, the national guidelines. So Ella is a Senior Policy Officer at the Alzheimer Society, and they she'll be giving an overview of the key findings as well as what they will be doing next and what needs to change to make sure that the policies that are there at national level actually are implemented and reflect people's experience on the ground. So I think Elle's presentation is pre-recorded, so if we could have the video for that, please.
Hello, my name is Ella Robinson and I sit within the policy team at Alzheimer Society. I'm going to talk to you today about a report that we've just compiled on the dementia pathway in England, which highlights the inconsistent provision of high quality integrated care and support for people affected by dementia from diagnosis to end of life. The report is structured around 4 stages of the dementia well pathway: diagnosing well, supporting well, living well, and dying well. To produce the report, we used national guidance and legislation as a benchmark of what care people should expect. We undertook a thorough literature review of existing standards, pathways, and data sets. We ran focus groups and interviews with people affected by dementia, and we interviewed and surveyed professionals working in the field. While the research was done before the pandemic, we know that COVID-19 has exacerbated many of the issues that we highlight within the report. Before I go on to talk about our findings at each stage of the pathway, I think this quote really sums up the feedback that we got as a whole. For us, there was no dementia pathway. Everywhere I turned for help, I felt like I was walking through candy floss. Everywhere I turned, I met a sticky end. So first up, diagnosing well. What are the key issues and potential solutions? Our research found that opportunities to identify dementia early are being missed. Due to difficulties identifying symptoms for professionals as well as non-professionals, people are being misdiagnosed or they're facing unnecessary delays. GP training on referral criteria and diagnosis can be a barrier to facilitating an early diagnosis, as can the short consultation time GPs can offer to patients. Dementia assessment tools may also have an impact on the timeliness of a diagnosis. It's important that appropriate tests are used to avoid misclassification due to biases such as age, education, and ethnicity. Professionals told us that diagnosing people from ethnic minorities can be challenging due to people being concerned about shame and stigma and not viewing dementia as an illness. Another issue is variation in the number of people being diagnosed and starting treatment within 6 weeks of referral. However, assessment of variation currently relies on ad hoc audits. Regular data collection would support the initiation of service improvement projects. Key to facilitating a high quality and timely diagnosis are the appropriate staffing of memory services and good referral pathways. This must include occupational therapists. It must also include multidisciplinary meetings between memory service clinicians, neurology and neuroradiology to facilitate clinical case discussions. The way a diagnosis is given has an impact on people's experiences, but we heard about diagnoses being given insensitively, focusing on what people can no longer do rather than what they can. People should also receive a subtype diagnosis, but not all memory services can view brain scans, which is a barrier to diagnosing a subtype. Just to sum up the section, I wanted to say a quote from a carer of a person living with dementia who struggled for years to get a diagnosis. Because he didn't have a formal diagnosis, they treated him like he didn't have dementia at all. Moving on to the next section now, which is supporting well. We defined this as a person's immediate support needs up to around a year after diagnosis. Our research found that people can feel overwhelmed with information after receiving a diagnosis or receive insufficient information. To manage this, opportunities for follow-up discussions should be an integral part of the diagnostic process. Consideration must be given to how this support can be delivered, as often memory services are commissioned to provide a diagnostic service only. Following a diagnosis, access to a care coordinator could help people navigate the complexity of the health and social care system. However, there's a lack of clarity around the role, specifically who does it and what it involves. This means people may not know who their care coordinator is, and professionals may not know they are someone's care coordinator. National guidance on this role is essential. People told us that access to a dementia advisor type service is also beneficial. However, to support access, the service should be integrated within memory services and primary care. Uncertainty over who should do what in dementia care is a key barrier preventing people from accessing the consistent care that they need. People with dementia will need to access a range of services and professionals, and they will need to access the same care plan. But people told us they have to explain their story multiple times to different professionals. Professionals told us they have to try to piece together disjointed information. There must be more integration of care and support plans between different services involved in a person's care. Advanced care planning is an integral part of the pathway, but there are mixed views on when these conversations should happen and on whether professionals are trained and comfortable to have them. There must be a more prominent role for advanced care planning within post-diagnostic support. This should be accompanied by clear levels of responsibility outlined at a local level. After a diagnosis, people should be offered post-diagnostic support interventions, but we heard accounts of inappropriate interventions that weren't tailored to individual preferences. The provision of interventions must be reviewed and made more appropriate. They must consider age, ethnicity, gender, and sexual orientation, and reflect the diversity of our society. We had positive stories of people feeling supported to improve their ability to carry out daily living tasks after accessing an occupational therapist. Other allied health professionals can also offer rehabilitation, such as physiotherapists, dietitians, speech and language therapists, and podiatrists. Allied health professional leadership on dementia and enhanced dementia awareness for allied health professionals are critical to ensure people can access these services. Again, just to finish on a quote, "The only support my husband and I had were things I had to discover and instigate myself. We were given a life-changing diagnosis and then left to our own devices to navigate the complexity of the health and social care system." Next is living well. So we defined this as around a year after diagnosis. Our research found that people receive limited access to coordinated, proactive, and ongoing care and support. Follow-up care, particularly from GPs, is not the same for everyone, meaning some people are left to manage their own condition. Annual care plan reviews aren't happening consistently, and they're not matching people's expectations of understanding how their dementia is progressing. Future service design should consider how primary care can be enabled to provide more appropriate and integrated care, or it should consider where responsibility for dementia lies in terms of primary or secondary care. Within a dementia pathway, few non-pharmacological interventions are provided after the initial diagnosis, or they're harder for people to access once they've been discharged from the memory service. Initiating more opportunities within the pathway to access post-diagnostic support interventions, both for people with dementia and for carers, would help ensure that people who declined the initial offer or are in crisis can access these. Many people receive most of their support from their primary informal carer, but carers are struggling to access support services due to inconsistent assessments of their needs. We also heard that many carers are left to research local respite care services themselves, and an accessible list of recommended places would be preferable. Formal support for people with dementia can also help carers to continue in their role, but having to pay for care and endure financial assessments can deter people from seeking support. Another deterrent is the lack of culturally appropriate care, which must be addressed by local authorities. Dementia care in hospitals and care homes can be variable. Within hospitals, there are issues with discharge processes and NHS continuing healthcare assessments. Within care homes, there must be access to clinical input to reduce unnecessary hospital admissions. This includes access to allied health professionals who can transform health care and well-being. All health and social care professionals involved in dementia care should be trained appropriately. I just wanted to finish on a quote from a daughter and carer of a person living with dementia. "I am constantly having to search for culturally appropriate carers, speak to the council, and get different healthcare professionals and services to speak to each other. It all became too much, and I had what I would describe as a nervous breakdown." Moving on now to the last section, which is dying well. Because there is much focus on living well, end-of-life care for people with dementia is often overlooked. This is made worse by a lack of awareness that dementia is a terminal condition. People told us they struggled to access palliative care, including end-of-life care. People with advanced dementia who are nearing the end of life will have complex needs. They typically have a high level of symptoms, leading to frequent hospital admissions and, in turn, high health and social care costs. Some people with dementia are unable to communicate their symptoms, which can affect how far they're managed. Action should be taken to manage hospitalisations, such as better integration of services and the upskilling of care home staff. To date, there has been a strong policy focus on place of death. Care homes are key to reducing the number of people with dementia who die in hospital, so more must be done to improve comfort and quality at end of life within care homes. We know that the number of people dying at home and in care homes is set to increase. There must be an expansion of capacity and end-of-life care training for staff in care homes and in home care services to sustain deaths outside of hospital. Finally, a quote. In the 13 months from December 2017, when Mum was first identified for palliative needs, right up until her death, absolutely nothing was done to provide Mum with the palliative care and support she required. To conclude, we found that from diagnosis to end of life, people with dementia face challenges in accessing effective care and support. A recurring theme at each stage of the pathway is the sense of disjointed, fragmented care. While the report makes recommendations for government and national bodies to make further progress on dementia care, quality and outcomes, it is ultimately local decision makers, services and professionals who are best placed to take ownership of developing dementia pathways, promoting streamlined and consistent support. Thank you for listening.
That's great. Thank you so much, Ella, for the presentation and for taking us through that really in-depth piece of work that you've done there. I think someone in the chat said there it's a really sort of simple but it's very effective methodology and way to present the results there, comparing what people should be experiencing and what the policies say they should receive versus what their actual experiences are, as well as providing solutions and suggestions for how these areas can be addressed. So thank you for taking the time to present there. I'm pleased to say that Dr. Louise Hopper has been able to join us, and she's going to present on the subject of the Irish Dementia Registry and its development, specifically on the identification of outcomes and data that matter the most within Ireland. Dr. Hopper's background is as an assistant professor and chair of the Psychology Ethics Committee in the School of Psychology at Dublin City University. She has extensive experience working with older adults and people with dementia and their families on projects involving assistive technology, timely access to formal community-based dementia care, and the design of the National Dementia Registry, which I just described there. So I'm pleased to hand over to her just now, and we can put her presentation up now, please. Thank you very much.
Thank you very much, Owen, and thank you on behalf of myself and Christina for the opportunity to talk to you this morning. And I really have to apologise, I'm in Ireland and completely never even thought of the time difference. So that's why I'm a little bit late. So what I want to talk to you this morning about is the development of the Irish Dementia Registry, including the identification of the outcomes and data that matter most in our particular context. So I would also like to take the opportunity to acknowledge some of the people who are really important for us in terms of supporting the project. So if we could move to the next slide. We had a special interest group of people with dementia and family caregivers who were instrumental in providing their support and guidance the whole project. And a member of that group then attended our steering group with a range of different people with expertise in relation to patient registries, so from a clinical and a technical background. I also want to thank a whole range of existing dementia registries for their support, and you'll know who you are. And finally, the National Dementia Office in Ireland and the Department of Health for funding the project. So moving on then, the project followed from an earlier piece of work that we did looking at the feasibility of building a national dementia registry in Ireland. And we currently, we lack a systematic approach to the collection and analysis of dementia data in the country. And it's something that we've known for quite some time, and something that was recognised in our National Dementia Strategy that was published in 2014. So the aim of this project was to build a model for a dementia registry to support the gathering of data to improve dementia care management, to improve clinical outcomes, and to improve quality of life for people living with dementia. And one of the first things that we needed to do was establish exactly what type of dementia registry were we considering or did we want to develop. And we had, I suppose, a very, very clear direction from both our special interest group and our steering group that the primary focus of the registry must be quality improvement. So this would be a focus on quality rather than epidemiology, for example. So looking at the next slide, the registry is intended to provide data that will be useful to people with dementia and their families, so particularly in relation to diagnosis, to care, and to quality of life, to clinicians and service providers in relation to benchmarking, targets, areas for education, and so on, and to policymakers in terms of monitoring the ability to make better decisions, and the ability to kind of call priorities in terms of supporting and improving the overall standard of dementia care. So importantly, these priorities were also prioritized themselves. So within those objectives, the fundamental focus had to be on providing a valuable source of dementia data to improve care. That was the kind of the key focus. And then secondary to that was a foundation that allowed for quality enhancement more broadly. Third, for assisting dementia planning and policy. And the last one in the kind of hierarchy was what we termed being research ready. So we're not a research registry. That's not what we are aiming at. So we're not supporting specifically kind of clinical trials, for example. But the data that the registry will gather will of course be beneficial to the research community. So what we wanted was to build a model that would allow the data to be accessed at a point in the future by researchers, but only when kind of data comprehensiveness and quality had been established. So we're building a model that's capable of being suitable to research, but that's not going to be our primary focus to begin with. So looking at the next slide, then the other key decision that we made at the outset was the location of the registry. And although best practice around registry development does recommend having an independent registry, we're in a position where we have to make a very pragmatic decision based on the way that our health regulations work and on the kind of layer that they form from a legislative perspective on top of GDPR. So in Ireland at the moment, we only recognise one type of consent, and that is opt-in informed consent, which is very restrictive when it comes to registries. So but we do have a scenario where we can gather and maintain identifiable data without needing a person's consent, if it's maintained within the health service for the purpose of managing the health service and monitoring quality outcomes. So this is why we've made the decision to place the dementia registry within our health service, and it will span both health and social care. So by taking that initial approach, we can begin to develop the registry without requiring a full consent process. Now, obviously, when we open up the registry for research, that is something that we will need, but between now and that point, we are engaging with the Department of Health, and we are looking at potentially being able to offer other types of consent models, so opt-out consent, for example, but that's something that needs some further discussion. So looking at the next slide, then you can see that the next approach that we took as a project was agreeing the priority outcomes for the registry. So we wanted to make sure that we had the right number of indicators that we were tracking, that the answers that they would provide addressed the kind of important questions that people were asking or didn't have the data today maybe to be able to respond to. We wanted to make sure that the outcomes and the indicators that we were tracking were meaningful and that they had a distinct purpose. They had an application, that something would actually be able to be done as a result of having this information available. So we're looking at a sort of a combination of process and outcome indicators. We were also very clear from the outset that we're not going to be in a position where we can be all things to all people. So we have to be kind of aware that we can only manage a sort of a manageable number of indicators. So to get this particular discussion going, we looked at outcomes that were used by existing dementia registries. We also looked at those recommended by the Roadmap project. And we also looked at those kind of captured by standard outcome sets, like ICHOM, for example. We had a whole series of workshops that we held with a variety of different stakeholder groups. So some were held with particular groups of stakeholders on their own, so like people with dementia, for example, and others were kind of cross-stakeholder workshops where we had a variety of different clinicians, health information technologists and so on come together to debate the outcomes that would be most beneficial. And as you can see from the next slide, that we didn't just develop a sort of a set of outcomes that suited a particular stakeholder group. We had sort of broad categories very quickly became important across different groups. So they typically related to diagnosis, to use of health services, to the kind of supports that were available. Medication was a kind of a key outcome area in its own right, as was quality of life. And you can see that the types of things that mattered most to people with dementia and sort of family and friends who were caring for them tended to be the diagnosis, and particularly the subtype of dementia in particular. Not just serviceability and sort of service use, but where service gaps are. So where maybe there are inequalities in terms of the types of service that are available or that can be accessed. We have both a public and a private healthcare system in Ireland, and there was a very clear need to cover both of settings across both of those, that people with dementia can move between the two settings. And also then quality of life obviously was hugely important. And for people with dementia, their understanding of quality of life was as it related to social engagement, to being able to do the things that they wanted to be able to do, and driving was mentioned on a couple of occasions. You can see in the next slide that in relation to the other stakeholders, there was also a kind of a key focus on quality improvement. And that was around the diagnostic process itself, planning care, treatment, living well with dementia. We certainly looked both at the use of health and social services and at the kind of economic burden of dementia. And also the idea came through very strongly here as the need to future-proof the model. So policy, data, assessment methods are changing all of the time. So it's a very sort of, it's very much an evolving environment. And it's important that the model can take that into account. So it was clear that there were a lot of people with a lot of different perspectives. So we had a range of about, I think it was about 28 potential outcomes that we asked to be prioritized. And on the next slide, you can see that all of the stakeholders went through a prioritization exercise. So you'll see on the next slide that there was kind of a clear kind of top 5, 6 that came through across all of the stakeholders. And the mean that's displayed here is across every group who provided their ratings. So you can see there that the kind of top indicators are ensuring that people go through a sort of a valid and a clinically sort of standard dementia assessment at the outset. Quality of life for the person with dementia and for the carer came through very clearly in the top 5. The specificity of the dementia diagnosis was hugely important. And then you can see that there are 2 pieces that are very important in an Irish context, and that's the proportion of people being treated with antipsychotic drugs, and also time waiting for home support services. So these would be community-based services were very important. So all of these outcomes, and particularly the kind of top 5 or 6, really drove the development of our minimum data set. So if we look at the next slide, we came at the development of the minimum data set from 2 directions. So top down was very much driven by our outcomes, but we also kind of came at it from a bottom up perspective as well. So we looked at the typical data that was collected in existing dementia registries. We looked at data sets from the Swedish Dementia Registry, France, Norway, Denmark, and a range of other settings. And we looked also at sort of standardized data sets that were recommended by the WHO and by ICHOM. So when we brought all of these together and kind of amalgamated it with the type of data that we would need to gather in order to meet our outcomes, there was quite a lot of overlap. So we then went out to our memory clinics and to our hospital-based outpatient clinics, and we looked at the sort of data that's available.
Louise, sorry to interrupt you. Could I just ask you to draw to a close in a minute or a couple of minutes? It's just that we're coming towards the end of the session. Sure. Sorry.
That's no problem, isn't it? There's not too much more. So if I get you to move to the next slide. So we found there were a couple of potential gaps, but you can see here very clearly that there were 4 key types of data that we need to collect. Data about the person, about the service provider, about the assessment and diagnostic process, and about treatment and care. And looking at the next slide, you'll see that actually we have a very good, it's sort of like a traffic light system. So we have a lot of data that we need around the person and the provider. We have pretty good data around diagnosis, but it's not very standard at the moment. But we have a very poor quality of data around treatment and care. So looking at the next slide then, we had no one source for the data that we could go to. So we are recommending with our model that we take very much a phased implementation approach. So our goal will be to get to sort of an electronic health record data warehouse scenario where you can not only look at dementia data, but dementia and diabetes, dementia and smoking. So you can look across conditions. But where we are right now and what our first implementation will look like is about making the most of what we have at the moment. And it's about concentrating on standardizing the data in our memory and hospital-based clinics. So if you move to the next slide, in conclusion, there are a number of other kind of key partnerships and projects that need to occur for the Dementia Registry to be successful. This isn't something that we can work on our own. So there's standardization programs around the data, there's looking at care pathways and models of care. And moving to the last slide, if we see, you might ask the question, well, why do it now? Why not wait until we have individual health identifiers, until we have EHRs? And we're kind of saying, well, look, you could be waiting forever for that to happen. So there's a really clear consensus from our group, from our steering group, from our stakeholders, that actually now is really the right time to be doing this. And that the key is working on what's achievable in the short term with an eye to the future, to down the road. So I'd be more than happy at any point to take questions. And if anybody wants to contact me separately to talk more about the project, my details are on the screen. And our report will be published next month. So I'd also be very happy to share that with you when that time comes. So thank you very much for your attention.
Thank you very much for your presentation. It was a really, really fascinating and interesting insight into how you're approaching this topic. I know that it's something that's come up in quite a lot of discussions in different sort of policy venues about what are the practicalities of doing this in terms of some of the legal implications that you described, in terms of actually what does the data set need to collect, how is it used, etc. as well. So to see how you grappled with some of those issues is really, really interesting. We are right at the end of the session, thus I'm not sure we have time to take questions. I know that some have been put in the chat, and I think both Nils and Ella have answered some of the questions within the chat there. However, if there's anything that you've asked which hasn't been answered, I would really encourage you to make use of the platform. You can find in everyone's individual profiles, and you're able to send them direct messages. You're able to leave questions on on different bits of the conference platform where the presentations are as well. So I'd really urge you to make use of those features and to get in touch with people and begin and continue these discussions if you've maybe not got all the information that you were hoping for. Some people have also asked me as well about the presentations. They will be made available after the conference has concluded today. It will take us a bit of time to upload them, of course, but they will be available for you after the conference has concluded. So all it remains for me to do today is to say thank you so much to each of our speakers for taking the time to be here and to present and to have provided this really, really useful and insightful conversation. I hope that everyone on the chat has found it as informative and useful as I have. There's definitely some points here that I want to follow up on, and I wish you well for the rest of the conference. I hope you are enjoying it and continue to enjoy it. And just to point out that there are 2 live special symposiums which will be taking place at 1 p.m. One's focused on dementia care and COVID-19. The other is focused on, sorry, I've got the wrong sessions that I'm focused on. Where are we? Sorry, the 2 sessions at special symposiums at 1 p.m. One will be from the European Association of Neurology, which will be on medical management of dementia, and one will be from Biogen, which will be looking at from brain health to Alzheimer's disease, addressing the challenges early in the patient journey. So I would really encourage you to attend those. I'd also encourage you to attend the exhibitors and our sponsors, who have specific sections on the platform where you can go and get information, resources, which have been uploaded. So thank you all very much for attending, and enjoy the rest of the conference.